Hello, and welcome to the fourth and final session of the SDOH Academy's Learning Collaborative on Addressing Social Determinants of Health in Rural Areas. My name is Kristen Steimanoff. I'm with Health Outreach Partners, and over the course of this four-session learning collaborative, we've been joined by our colleagues at Migrant Clinicians Network, the National LGBT Health Education Center, and Capital Link. Our session today is going to be led by Mark Lurtz at Capital Link, and you'll hear more from Mark in just a few short minutes. And we're also very pleased to welcome Dale Fiedler and some of his colleagues from the SIHF Healthcare. I recognize many of the names on our schedule today, which is really exciting. Oh, Mark, can you go back to that last slide?
Yeah, sorry.
Thanks. It's okay. Recognize many of the names, which is great. I will just remind those of you who haven't been with us before of where we've been and where we are today. So we started on November 6th, and my colleague Christina Wharton and I started talking about issues, risk factors, and health disparities in rural areas. And we introduced understanding unmet need and connecting people to care. And then on Tuesday, November 13th, Theresia Lyons and Alex Karoglian, Theresia from Migrant Clinicians Network and Alex from the National LGBT Health Education Center, talked about understanding trauma to meet the SDOH needs of rural populations. Last week, Jillian Hopewell from Migrant Clinicians Network and Alex Karoglian from the National LGBT Health Education Center talked about challenges and opportunities for collecting SDOH data. And they reviewed some of the data sources that we had talked about in session one and introduced additional data sources like PREPARE and sexual orientation and gender identity data collection opportunities. And then presented, so let's do some muting for the panelists. Great. And they presented some case studies about how SDOH data is being used in health centers to improve services to patients. And then today we're going to talk about challenges and opportunities for infrastructure development. And we're very excited to have Mark walk us through these processes and to have Dale and his colleagues give us a really on-the-ground perspective and some opportunities for using partnerships to really improve capital projects. Now you can go to the next slide, Mark. As we've been doing for the first three sessions, we're going to be using GoToWebinar. So hopefully you're familiar with this by now. You're all in listen-only mode for now. We will present all of the content to you between now and the top of the hour. And then if you're able to stay, we've been having really wonderful, robust discussions, and we can facilitate a discussion so you can ask questions, share your own experiences, and we can use a couple of different tools there. The question box is where you type in a question or a comment, and you can also click on the little hand raise and raise your hand and we can call on you. And we can actually unmute you so you can have a discussion with your voice. Before I turn it over to Mark, we'd love to have you all introduce yourselves. So why don't you take a moment and type your name and organization name in the chat box, and we'll do a little roll call. Okay, it should be coming up for me shortly. I see some people are typing in. Liam and Christina, for some reason, I'm not seeing the chat quite yet, but I know last time there was a bit of a lag and then it showed up. If you're seeing something, let's see. Are you seeing people's names in there, Christina?
Yeah. So we have Ashley from Shingletown Medical Center. We have Whitney from the Kentucky PCA, Olivia from Montana PCA, Heather from Bi-State PCA, Donna from Central Counties Health Center in Illinois, Kevin Walsh, Eileen from MVHC, Community Health of Central Washington, that's Kevin Walsh, Margaret from CRCHC, Kathy McDaniel from Community Health of Central Washington in Yakima, Washington, Shelley Harden from Healthcare Collaborative of Rural Missouri, Theresia from MCN, Nat Cortez from Montana PCA, Shelby from Molokai Community Health Center, and Leslie Southworth from MPCA. I'm not sure if that's Montana PCA again. Yeah, so that's all we have through our question box. Thanks, everybody. Oh, Hillary also from Health West in Pocatello, Idaho.
Great. Thank you, Liam, for fielding that. And of course, as you were talking, it showed up for me, so I appreciate it. Welcome, everybody. It's nice to know who's in the room. We're really happy with the folks that have joined us again for this 4th session. And without further ado, let me turn it over to Mark Lertz from Capital Link.
Thanks, Kristen. Let's see if this slide will advance now. Here we go. So as Kristen said, I'm Mark Lertz. I'm Director of Partnership Development at Capital Link. I've been on staff here for the last 18 years in a variety of capacities, including working individually with health centers on their capital projects. Capital Link was initially funded over 20 years ago by the Bureau to provide capital development assistance to health centers across the country. We provided resources and guidance related to planning for and financing capital projects, mainly for primary care related projects. As the cost and complexity of those projects increased, the need for more equity and creative financing became more important as well. So we introduced new markets tax credits to the industry and stepped up our work in educating lenders about health centers, mainly to attract more of them to the idea of financing health center capital projects. We also understand the need for health centers to have a strong foundation before taking on a capital project, so we added advisory services for strengthening operations, and we do have data support for helping to measure value and cost, as well as measuring impact of health centers on their communities. To support that work, we have improved our financial database with health center audits by adding UDS to measure the financial and operational strength of health centers. Capital Link has provided technical assistance to more than 2/3 of health centers nationally and has leveraged nearly $1.1 billion for 231 capital projects totaling over $1.45 billion. Big numbers, but there are a lot of small projects in that as well. So we have a brief amount of time to talk through a vast amount of information. So I chose to focus on these 4 critical areas, mainly on a higher level. I would say, please note, we have written resources and webinar recordings, plus additional upcoming trainings on these topics on our website that cover these topics more in depth, and I'm available by phone or email to answer additional questions too. All right, like most projects, there's a process for preparing for a capital project. While this is a short list of what you will eventually need in your toolbox for securing funding/financing for a capital project, our work plan manual has a much more detailed list and timeline and is available on our website. But this gives you kind of a sense of what the process looks like. So things to consider before you start. I'm going to go ahead and tap through these. Most health center staff know their markets well and have a good feel for what's needed in the community. The exercise of doing a formal market analysis, however, will help others see the need as well. To the point in this slide about there is a lot of data out there, well, there's a lot of data out there. And this only scratches the surface. The way to sift through isn't necessarily to go through all of it and determine what's fun or what seems the best. Rather, you might ask yourself some questions about what you think you need answered to make the case for the project. Things such as what are the population trends, or total population, low income population, your target market, your payer mix, things like that. Is there data supporting the specific program services you're seeking to maintain, grow, or add? Who else is providing support in these areas in the community? And are there partnership opportunities? Things like that, etc. To help shape how you present this information, I've included here a basic outline. It's a table of contents from one of our market assessments to provide you with buckets, if you will, so you can fill the relevant information within those confines. Once you begin collecting some of the relevant information for your project, you can begin to run some back of the envelope calculations to help you get a general sense of your market need and translate that into some loose estimated cost information. So I'm going to run through a little scenario here. You see some of the highlighted text here, the low income population of 50,000, 20% market share is what this health center has of that low income population. You can calculate the visits per patient at 3.5 by taking the FQHC visits and dividing it by the service area FQHC patients. And then further down, you'll see the 1,400 visits per FTE. That calculation comes from the number of provider FTEs and taking that 35,000 in visits and making those divisible. We'll use some of this information from a hypothetical market study to make some basic assumptions. And jumping forward. So this organization wanted to increase its low-income population market share by 20%. So what does that mean in number of patients, visits, and providers? I'm going to tap forward a little bit here. So you'll see there's two different 20%, and I apologize for that, but the low-income population market share, they want to increase that by 20%. So that's the 1.2, and they currently have 20% of the market. So if you take the 20% times the 1.2, you get 24%, and that's the share of the market they want. You multiply that by the total low-income market, and it gives you 12,000 patients, or a 2,000 increase in low-income patients. When you multiply that by the visits per patient, it gives you 7,000 additional visits. And then the 7,000 divided by 1,400 gives you the number of additional provider FTEs that it would take to meet those needs. With those 5 FTEs and some more estimating, this gets you closer as you get real numbers from contractors and by looking at what works internally. So again, we're taking a hypothetical situation, some estimated numbers. You take your square foot per provider as a basis. We're going to use 1,100, and you're going to multiply that by the 5 FTEs, and that gives you the total square feet you need to have those providers provide those services. Again, we're using an estimated cost per square foot. In rural areas, it may not be this high. We did pull this from the buildingjournal.com, which you can see at the bottom of the slide. And in doing so, you take the 5,500 square feet by the 300 per square feet, and it gives you 1.65 as an estimated cost. Now, you'll also need numbers to add to that space for other program spaces like community spaces, shared group rooms, SDOH-specific program areas, etc. Plus, you would add approximately 50 square feet for the team of providers for their waiting space, and an additional space for building support and maintenance as appropriate. Again, back of the envelope, but just gives you an idea of how to run some numbers early on to give you a sense of what this will cost. Typical breakdown of costs, it will give you the hard costs, which you can use to back into the other numbers, the equipment costs and the soft costs. However, and that gives you your total project cost as it relates to the building itself, or the building of the building, if you will. Of course, land acquisition / building purchase would be a potential separate cost for you. So to expand or not expand, that is the question. So look at your existing space and ask yourself these questions, both to see if working with your current space is an option and to consider the space going forward, whether you choose to stay or if you're going to move. How much risk are you willing to take? You're looking at a base level, you're looking at maybe something a little more, or I don't think I would do this one. But does the evidence we just spoke about, and which is only the beginning, support your conclusion? Can you take on more risk, or should you take less? But don't worry, there are lots of tools to help you answer these questions and more. Looking at your historical performance for 3 years and audited, it gives you a sense of where you were. Then you want to jump into a 5 to 7 year forecast. I have 7 years in there because for certain programs, including programs like the New Markets Tax Credit, it does require that when you go to a lender. Looking at a project budget, building that into sources and uses, and then the financing structure. These are all part of financial feasibility and sustainability. I believe there was an email about running your historical debt capacity sent out. It's a tool on our website. Is that correctly? Sounds like someone was saying yes. By entering your information in the top 6 categories, clicking on Calculate will provide you with an estimate of your debt capacity based on historical information, and that is current operations. So for instance, if your top 3 categories added up to $951,047 at a 6% proposed interest rate and 20-year amortization with no rent rebate included, the following would calculate. So funds available for debt service in 2017, which would have been the year that you entered, would be $951,047. The reason this has multiple years is because we ran a number of different years. The rent rebate below is at 0. However, if you're currently paying rent on a facility and you're replacing that facility, the rent payments that you utilize for that, you'd be able to take that and put it toward the debt service. Then it calculates for you the funds available for debt service after applying a debt service coverage requirement. They're typically 1.2 to 1.25. Lenders require that amount to be set aside, basically so that you have some cash available. But that reduces the amount that you have available to $768.38. And then, as you can see, depending on the interest rate and the years of amortization, it'll calculate for you what your available dollars would be for debt capacity. Please note also here that the number of years in the amortization is not necessarily the term. The term is typically a lot lower, particularly with conventional loan, which is normally anywhere from 5 to 10 years. So of course that exercise is for current operations, and all lenders will want to see how the new operations incorporated into your financials will sustain the loan. Not only them, but you should want to see the same thing. So you want to complete a statement of activities beyond this statement of financial position, which is an income statement, your cash flow statement, and patient revenue and employment projections by service type. These next few slides are examples of these projections. We do include a blank template of this in our business plan manual on our website. Business plan manual is a great place for all the information we talk about here as a landing place, so that you have everything together. So once you begin to realize the project is a real possibility, you can start to fill in a project budget to make certain you cover all the costs the project will include. Now, this is not an exhaustive list, and we actually have a more detailed project budget, again, in the business plan manual on our website for your use. As you consider SDOH, you may also have other costs to include in the project in one or more categories, but don't forget to make space for those. The first three on this page is for your property or building, and then just below that are your hard costs for construction. You'll have many soft costs as well, which are your planning documents, those things not associated to either your hard costs or your furniture, fixtures, and equipment, which is the next component. Some of the furniture and fixtures and things that you have, if you're staying, there won't be as much of a cost, so that 70-15-15 might change. But the idea is that if you're going to a new facility and you purchase new things, that 70% hard cost, 15 for soft, and 15 for equipment usually does apply. So now that you have a working detailed project budget, it can roll up into a sources and uses of funds chart. This gives you a sense of what is needed from the funding standpoint, and you can begin to build out the sources side, and they should match. So for sources, we'll use financing as a loose term here, since your project will hopefully identify some equity funding for the project as well. In my years here at Capital Inc., I have yet to see or hear about a project that was only funded with one source, as there are typically at least three. Those funds can come from a lot of different places, as you can see here, and some will be specific to your area. Rural areas typically have a more difficult time identifying equity for projects unless they have a major manufacturer in the area or a larger company that has a site nearby and they have a foundation component, or that they're willing to provide some sort of grant to your project. And basically they do that because it's a benefit to their employees. So definitely talk to any larger employers in the area, which works both in the urban and rural settings. So whether urban or rural, projects often utilize some combination of grants and gifts. As I mentioned before, New Markets Tax Credit is a good program. They have a 20 to 25% equity put as part of that, which I'll talk about more in a minute. You have state funds, and there are states that do have the PCAs work on getting funding from the state for capital projects specifically. Others do have some loan programs or low interest loan programs that you can access. Foundations are a great source, obviously. And then you have your different types of loans, and a lot of projects do use cash reserves that they build up over time to save in order to put toward the project. And then finally, the loan guarantee, the HRSA loan guarantee program, which ran out of money a couple of years ago. They are reinstating it, and we should see something in the spring of next year from that program. So, and then one rural source not available to urban areas for the most part is USDA. They have some smaller grants available for capital projects. They also have access to loans and loan guarantees in their community facilities program. Also, I should mention that CDFIs, which are community development financial institutions, they lend in a variety of capacities and are focused on development in communities, including things like healthcare, which is good, charter schools, housing, grocery, etc., depending on their specific mission. So here's an example of a conventional bank, and I put or USDA loan because they typically run about the same from the standpoint of what you have to put together to access the funding. So this loan is 80% of the project value, $8 million, interest rate 6.5% with a 25-year amortization. That's the bank. The interest rate is lower often by a couple percentage points compared to this scenario for USDA loans. The question remains, where will the other $2 million come from? Will you sell your building and use the equity from that? Good partnership with the hospital. State economic development programs sometimes have some dollars for capital projects. Capital campaign, if that's something that you're planning to do, you have a board for it, or if it's something smaller that you do, every little bit helps. And then government or foundation grants. So our sources of funds looks like this. We have a bank loan of $8 million, other, which would be specified by the individual project of $2 million for a total of $10 million. Annual debt service, principal and interest is $655,000. So for our new markets tax credit program, there is a piece, as I mentioned before, investment that isn't repaid. Typically it's 20 to 25% of total project cost that you don't see until the end of the 7-year period, but it's still equity towards your project. Eligibility for this program, you're typically looking at projects 5 million plus for it to be worth it, because it is high cost to get into. Finding a community development entity, they are the ones that attract, they do an application, and they're the ones that attract the tax credits through allocation from the community development, the CDFI fund. So the investment, approximately 20% of project costs, bank loan for the balance, which funnels into the new market structure. It's an $8 million loan, interest only, for 7 years at the same rate as the bank loan. $2 million in quote unquote free money. And then the bank loan is $8 million, new markets of $2 million for a total of $10 million, but the annual debt service is only $520,000. The reason for that is it's interest only, and it is for 7 years. So you should do that sort of exercise for all the potential loan offerings. A debt comparison analysis like this will help you determine which are the best fit. You may need to add some categories along the top to help you further evaluate, though, like the eligibility for new markets or availability for the programs and any other idiosyncrasies. Plus, do they fund what you need? But looking through this, you have your financing source. How complex is it to access the dollars? Time to closing? How quickly do you need the funds? Upfront costs. Again, some of these programs are easy to access. They don't cost much, but you have to look at the cost benefit. For the new markets, you get 20-25% equity, but it's a little higher. It's actually quite a bit higher to go through that process. But again, you do have that equity put at the end of the 7 years. Your interest rates, look at those and see, for instance, the USDA is going to be lower than most of these from an interest rate perspective, if not all. The only other one might be tax-exempt bonds that are a low interest rate. And then your size of borrowing and your term. Again, your term, as I stated before, is the payback time frame before you have to either pay off the loan or go ahead and refinance. So as I mentioned earlier, Capital Link has a large number of resources to help with your capital project planning, to help you frame the tools that are needed to move ahead. This gives you some examples from our website. At the bottom there, we also have webinars and resources available at the website. A lot of these are toolkits or how-to manuals that kind of guide you through the process. So I like the fact that a lot of them are do-it-yourself, but of course, as I mentioned before, we are also a resource for you when you hit a snag and have questions, so please feel free to contact me. These are just photos of the front page of 3 of, I think, the most relevant capital planning, financing resources for you. The capital project work plan has a timeline built into it. and is a good overview of the process that you'll go through for a capital project. And then, as the name suggests, selecting the right capital project financing will help you walk through scenarios like we just talked about. And then the business plan manual on the right side there, it is a how-to manual. It walks you through the different components that lenders look for. It is utilized by a lot of different lenders for health center loans to evaluate whether the loan is financeable or not. So again, I'm Mark Lertz, and you can reach me directly at the number there or by email. So at this point, I'll turn it over to Kristen and Dale.
Thank you so much, Mark. And we're just going to turn it right over to Dale. So Dale, if you are ready, we are ready.
Okay. My name is Dale Fiedler. I'm with Southern Illinois Healthcare Foundation, and now we've changed our name to SIHF Healthcare. I've been here about 29 years.
Dale, I'm so sorry to interrupt. Pause for just 1 second. There is a little bit of echoing.
I can use my phone.
Okay, try that.
Okay.
No, that's not working. Bring that up there.
Dale, try muting your computer.
Yeah. Got it.
Mute your computer.
Okay, just a second.
Okay, I muted Dale for just 1 second. Let's see if we can support him in doing this, as always.
Okay, I think we're muted.
Okay, I just unmuted. Would you like me to mute you for a second? Okay, there you are. But you're echoing. And what can cause that is if you're connected to phone and computer. You need to choose just one. All right, I'm going to mute you for a second.
Okay, how about this?
There, that sounds great. That's perfect.
Turn your speaker back up.
You sounded perfect what you were just doing, Dale. We can hear you well.
How about this?
Yep, you sound real good.
How about this?
Perfect. Just go right ahead like that if you can.
Okay, how about this?
Can you hear me, Dale? You sound great. If you can just
Okay.
go forward with your presentation, you sound really good.
All right. Well, after a little rough start there, I am Dale Fiedler. I'm with SIHF Healthcare. I've been here about 29 years. Have been involved from when we had one little small site to where we are today. We are one of the larger health centers, over 100,000 patients, about 34 sites. We're in 11 different counties, 2 urban, more urban type counties, and the rest are more rural. We have a small family practice residency. We have funding from all 3 of the special POPs groups. The crop that we grow around here, other than corn and soybeans, is horseradish. So about 80% of the nation's horseradish comes from right in just a few mile area around us. And we also have a fairly large behavior health component, with about 10 psychiatrists and about 3 psychiatric nurse practitioners, as well as LCSW types. SIHF is structured as the community health center, and it is a parent corporation to a safety net hospital, and also more recently to a community mental health center. As the parent corporation, the Community Health Center Board of Directors appoints the board of directors for the hospital. We also corporately also have 5 partnership corporations with 5 different housing development activities, which we'll go into a little bit later in the presentation. Right now, I'm going to turn it over to Ron Finnan. Ron comes from the Mercy Health System and has been with us all of about 3 months. Something like that. There you go, Ron. Next
Thank you,
slide.
Dale. As Dale said, I'm Ron Finnan. I'm the Corporate Vice President here at SDOH Healthcare. I have about 30 plus years of ambulatory care, come from a nursing background in administration. So I appreciate this opportunity to kind of share some of this information. So today, as we talk about the, we can go to the next slide. When we talk about collaborative partnerships, I think it's important to understand that as we look at these partnerships, if we could click our heels and pretend that we're Dorothy in Kansas, we would have all these things come to us. But understanding that we cannot be all things to all people from the organization itself. However, finding individuals or organizations that would benefit our organization as well as be a benefit to them is really how collaborations need to be. I had a mentor years ago say to me, you find people who you like working around or like being with, or you say, I want to be a part of their team, and oftentimes either hire them into the organization or form a collaborative partnership with them. So next slide. The collaborative partnerships are important to understand that there has to be a shared value and a shared commitment for the long haul. The information that is shared back and forth oftentimes is months and sometimes years to develop those things, but the mission and the values really are important to be clear between both organizations. As a clinical nurse, the next topic there really becomes, I believe, the important thing as we deliver healthcare, and that is, can we prioritize patient care? And understanding that both organizations, as they come together, really have that opportunity. But alternatively, if one of the entities is driven primarily by short-term revenue goals and the other by customer satisfaction, the two may not be as well matched as we would like them to be. And so finding those partners is really important. I go back to our HR friends when they say, you know, hire the right person for the right place at the right time for the right position. And that is even more important as we look at collaborative partnerships. So next slide. If we identify a gap that really needs to be filled and identify maybe something or someone or some organization that could help us with that, ideally the combined entity would fill that void, and the combined strengths within them really can make a difference in the patient's life. We looked at recently the CVS issues, you know, CVS and I believe it's Athena. Are they Humana? Is it Athena?
Aetna.
Aetna. I'm sorry, Athena. I just came out of an Athena meeting. CVS and Aetna, you know, what is that partnership really going to do strategically, and how does that work so that it really benefits the patient? It'll be interesting to watch that as CVS and Aetna and Walgreens and Humana kind of take both the same pathways, and hopefully they're both, you know, very successful in what they do. So, all right. So next slide. What do we really want to see as we look at this collaboration? Number one, we want to see you know, that long-term commitment to sustainable change. Secondly, that there are some innovative mindsets. You know, when two organizations come together, the old adage, you know, more heads are better as you think about those things. But there are things that are brought together from different organizations. And so important to understand that, you know, there may be some differences as we look at this. Make sure that we are both entities have a commitment to effective technology or effective use of technology, and that the long-term objective really has to be a profitable solution that creates a higher outcome for our patients than what they currently have. So next slide. The collaboration really should be kind of a celebration or an aha moment, kind of, you know, sitting at a fireworks show and seeing the beautiful things, you know, go off in the sky. But it requires a commitment to be innovative across the board, and whether it's in the delivery of care, creating workflows, contracting with providers, the financial incentives. There are a whole lot of things, but making sure that the final product is, the finished product is really a good fireworks show, as you might say. Next slide. So we agree that our country's healthcare system is broken, and this really is not a simple task. But our best chance for achieving any sort of transformative care or transformative change has to be sustained. Jim Collins writes in his book, Good to Great, you know, he talks about making sure that when you go to look at changes or implement changes, that you stake them in well with the organization, that they're safe and they're, you know, all those things that are important. The other thing is to look at, you know, maybe another organization might have something different or a complementary skill to offer the organizations as they come together. Next slide. And then as I wrap this up, it's just important to understand that there has to be a triple win mindset. The win-win for both organizations coming together, as well as, you know, what is the win for the patient? We know that these wins aren't really simple, but we have to be motivated to succeed as we move forward on this. And in the right model, everyone includes all the stakeholders. And, you know, what is the win for the stakeholders? And creating the access to appropriate resources. And then how do we share this win mindset so that it drives collaboration, it drives transparency, and lastly, it's a joint commitment to really attaining those long-term goals. So I would just encourage everyone to think about the opportunities that lie before you, and don't be afraid to go out and meet with individuals and say, you know, hey, would there be any opportunity here for us to possibly work together? So I'm going to turn this over to Nancy Haas, who's our Director of HR and Insurance, and she's going to talk a little bit about the employment piece.
Thank you, Ron. My name is Nancy Haas. I'm the Corporate Director of Human Resources and Insurance, and I'm going to talk about a specific area of a key to social determinant of health, which is employment. Obviously, if a person has employment, it's going to drive income, it's going to drive their job satisfaction in helping others have intrinsic rewards, which also has a positive impact on the individual's health. The self-esteem of an individual who gets a job for a first time or has a higher level job that's not a menial job, the self-esteem rises, a sense of purpose rises, as well as my history is seeing first-generation workers soon introduce their children who become second generation, and their children who become third generation workers. And so the concept of employment is a part of what we do, which helps drive obviously upward mobility as well as improving health outcomes. One of the things that we have done with SIHF Healthcare is that we have developed some key partnerships, both urban and rurally. If you would go to the next slide, please. And I'm going to talk a little bit about some of the partnerships that we've developed one of our rural and urban, and the first one we were involved with is Lewis and Clark Community College in Godfrey, Illinois, set up a medical assistant program, and their target population was not your typical student. It was people who were perhaps bartenders or club managers or people who were working as stockers at Walgreens. Lewis and Clark introduced this program, and we became a partner right off the bat, offering mock interviews to the candidates as well as externships. And we provided externships both in our larger communities as well as our rural locations. This was an excellent opportunity for the organization to preview the candidate and get a look at the work ethic and how they would fit within our center. And to this day, we are on our third year, going into our fourth year of the program. And I would imagine, as an estimate, 90% of our externships end up as SIHF healthcare employees. A new program we've developed with Southern Illinois University Edwardsville, their East St. Louis campus, which is an urban campus, is we provided a letter of intent to help support a grant they received, which is providing paid education and paid externships for people whose children are in Head Start. They've proved to be reliable. They're in a medical assisting program, and they will soon have externships with us with the opportunity of employment. And down the road, this program is going to introduce an LPN program as well. Next slide, please. Lakeland Community College is a new program, a new partnership we developed in Mattoon, Illinois, and Central Illinois. Typically in Central Illinois, there are no medical assisting programs, and you can only hire LPNs and RNs for jobs that would typically be better served by medical assistants. We've partnered with Lakeland. We're going to provide externships, mock interviews as appropriate, and then again, the opportunity to hire into our rural clinics. And finally, our Beck School of Practical Nursing in Red Bud, Illinois is a rural LPN program where we're providing opportunities for observation, going to their job fairs, providing mock interviews, and offering job employment. Next slide, please. I'll turn it over to, one last thing I will say, well, I'll wrap up real quick here, and that is, in all of these programs, and sort of keying off of what Ron talked about, is establishing a partnership with the organization that's providing the opportunities is absolutely critical. It's very important to establish a rapport with the leadership of those organizations so that if there is a hiccup, it can be quickly addressed and it doesn't have an impact on the organization. We just learn from it and move on. And finally, having flexibility with the programs in seeking that partnership, what as an organization we can help them to help make their program successful. So that's one of the learnings that we have come up with out of our employment and relationships with our local colleges and junior colleges. I'll turn it over to Dale now.
Thank you, Nancy. Go back one slide, please. Okay, great, thank you. We do not have a functioning YouthBuild program, but I did want to throw this in at the end. We are awaiting news as to whether our application is funded or not. We should hear it just in the next little, anyway, I'm expecting to hear it at any day now. YouthBuild, just to really quickly touch on it, it's a Department of Labor program. It benefits both rural and urban locations. There are a number of rural YouthBuild programs around the country. This was really our very first exposure to YouthBuild. we partnered with the Urban League and Rankin Technical College, which is a very well-respected trade school in the area. YouthBuild, they take low-income youth who have dropped out of high school or are not achieving at appropriate levels, and YouthBuild provides a supportive learning environment for them. Again, it's something that I think fits some of our community health center patients very, very well. And one other thing that we kind of learned as we started down this path is that there is an entity called the National Institute of Medical Assistant Advancement. It's a relatively new organization that was started by a community health center in Connecticut. They are currently in a couple of states now, and Colorado has partnered with them very closely, the Salud Health Center there, and we did most of our negotiations with the program with the individuals out at Salud. Let's see. But they provide, that program is an internet-based as well as interactive webinar with cameras and things program, which it's a kind of expensive, but you can perhaps have the cost of that offset by your local WorkNet program. At least that's what they're called, WorkNet programs in Illinois. I think that's also nationally, but it's basically it's the old unemployment office for the older folks. They've gone through several name changes and iterations. We are currently with our local WorkNet office just getting started on an incumbent worker program. We're having our first meeting in 2 weeks from now. So. A very good, if you don't know your local WorkNet folks, it's very, 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 a very worthwhile entity to get to know. Next slide, next two slides actually. Next slide. Okay, there we go. You know, we all know that transportation, you know, works kind of hand in hand with social determinants of health. We know individuals, many of our patients have unreliable cars, depend on friends for to bring them to appointments, and frequently results in missed appointments and other issues. This also impacts just their you know, employability, et cetera. Next slide. So. Way back in the early 1990s, in our area, transportation was really the priority community problem. And this slide and kind of the next little bit of information is really going to be if you're thinking about starting your own transportation program. As we looked into this, we found a federal state program called the 5310 program. And what that does is it purchases a van for you. There's a lot of red tape involved. There's a lot of letters. And these are letters of support which really do make a difference. These letters need to come from the other transportation providers in the area. So it's very important to develop relationships with them prior to starting down the path of getting your own vans. The process takes 2 years from about the time you submit your application. It's long. There are significant regulations in terms of the operations of that. And we found that that as a community health center, we were not able to bill Medicaid, so that would greatly impact the feasibility of operating a program. We could have a nice new shiny van sitting there, but not be able to afford the gas for it. So we partnered with our local community hospital, and they supported through Medicaid reimbursements, as well as some Healthy Start grant money goes there. And currently there's, I guess, at least 10 vans and 10 to 15 employees by the time you figure in your dispatcher and manager, et cetera. In the rural, next slide. In the rural setting, could you advance the slide? Hello?
It's moved.
Oh, thank you. Okay. We recognize that transportation in the rural area is a significant issue, and we have found that it's really best to partner with your regional transportation providers. It would just get very expensive to operate on community health center funding. You know, your rural transportation provider may very well be familiar with the 5310 program, but it may not hurt to mention that if you are in conversation with them. The 5310 program in our areas, or the rural transportation systems in our areas, include something called Rides Mass Transit, and also a CEFS Economic Opportunity. These are both community action partnership agencies, and I'm fairly certain most every state has, and most every area of a state is covered by a Community Action Partnership Agency, or the CAP agencies for short. Next slide. We also recognize housing as an important determinant of social determinants of health. Kind of harking back to one of Ron's slides about being everything to everybody. I'm going to cover hopefully a kind of a continuum of approaches to housing that might be right for your own particular situations. You know, as you know, housing dictates so much in social determinants. Let me kind of, I know the hour is getting kind of close. Let me move on to some of the structures. Basically, one way to impact housing is through working with your local community action agencies. They normally have weatherization, lead remediation, etc. Those community action agencies, they may also be, you may also find them under the Department of Commerce and Economic Opportunity in your state. If you go a little step further along a continuum, you might look at the HUD, the Housing and Urban Development. There's every year a supernova comes out. They generally come out in like January, February, or a little bit later. They come out with all of the different grant programs there. And we've applied a couple times for Healthy Homes way back a long time ago, and we're not funded out of that, but it appears that Healthy Homes is still around as another viable entity. So I would encourage you, if you want to take a little further step along the housing improvement line, might look at that. Next slide, or next slide, right? In terms of the housing financing projects, this is kind of out at the end of that continuum of risk, being really the most risk. My best recommendations kind of for everybody on this one is partner. This whole kind of like Mark was getting into, the language of the various housing development trust funds, low-income housing tax credits, new market tax credits. This all gets pretty, you got to have a pretty good understanding of that. And from I think really the best recommendation that we can do is to really provide you with, finding a partner that does this. We've worked with our first partner for probably over 20 years now. The first 5 years, we applied for HUD 202 funding, and we were turned down every year for that, and finally received it. And that was a housing project, a senior apartment, 75-unit senior apartment project that's been in great operations for little over 15 years now. These projects, they require really a combination of loan guarantees plus loans plus capital. They really do get involved. Now, because our organization has been working with the partners both in operating these projects and in attaining these projects, we have taken a more active role in the development of those. But that has really come after about 15 years. Now, you all may be faster and may want to do it on a more accelerated basis. That's really just going to depend on your appetite for risk and particular circumstances. The other entity that I want to mention here is CSH. You all may be familiar with that. That's one of the national cooperative agreements. They provide a lot of supportive technical assistance in that area. And we just, at this point, have just not really gone into a project with them, but that's really related to the history that we have with our current partner. Next slide. As I mentioned, Touche Elderly Apartments 1, that's now about 15 years old. Touche Elderly Apartments 2 is a 50-room apartment unit. And this is, by the way, these two are completely funded by HUD, and they are for individuals who can live on their own. And a couple of years ago, the funding for these was discontinued. So we have kind of taken the next step and developed the cottages at Cathedral Square, and you can look that one up on Google or any other search engine to find out more information about that. It's 50 units, and it's low-income senior housing. We currently have 2 more low-income projects under construction right now. Next slide. And some things that we're looking at for the future. We're always kind of trying to look out ahead, looking at some transitional housing for our behavioral health and substance abuse patients. That transitional housing would be more of that supportive housing that CHS talks about a whole lot. We've also had conversations with our local jail, and we provide care now on an outpatient basis to individuals from the jail. They bring them. We don't go into the jail to provide the care. They come to our hospital and health center. There's another project that's even larger, and that's really just re-envisioning kind of the whole community. So that community that we were looking at was identified as the number one poorest community in the nation by a USA Today analysis back in June. So that completes my presentation, and sorry I ran over just a little bit there. Thank you.
No problem. Thank you so much, Dale, and thanks for bringing in Ron and Nancy to share this wonderful information about partnerships and projects around housing and employment and transportation and the future initiatives that you have coming up. It's really exciting and inspiring, and I think, and it was good to hear both about the opportunities you're pursuing in your rural sites and your urban sites. I think it helps people envision what could be. Before we move into the discussion part, I just want to share a few quick reminders. So first of all, in case you missed any of the previous sessions or you just want to relive the experience of any of our sessions, all of the slides and all the recordings and supplemental resources are available in the Dropbox that we set up for you. So if you don't have the link easily available, just email us and we'll get it to you right away. I think you've been hearing from Christina Wharton a lot, so you should be able to get to her pretty quickly and easily, but we're all available for you. And finally, I do want to mention that the SDOH Academy is hosting 3 additional learning collaboratives like this one, but on different topics. They start up again in February. So in February, the topic's going to be training health center workforce to address social determinants of health. In April, they'll do 4 sessions that all get at leveraging Medicaid policies to address social determinants of health. And in June, the topic's going to be on developing cross-sector partnerships to improve health outcomes. And I know that many of you who've been joining us over the course of these 4 sessions have also signed up for one or more of those learning collaboratives. So I hope you will go forward and participate as planned, or let us know if you're interested but didn't get a chance to sign up. We'll see if there's any more space. But I will end with a plea for you to really be very honest in your evaluations, because you've been guinea pigs for us in this first learning collaborative of the SDOH Academy. So we want to hear, when you fill out your evaluations, what worked well from your perspective and what could be improved for future groups, because our colleagues are definitely going to want to apply the lessons that we're learning here with you. So with that, let's take the next 22 minutes, up to 22 minutes, depending on how much participation we have from the group, to talk with our panelists, to ask questions, to share our experiences. I'm sure that Mark and Dale are still on the line. I'm not sure if both of Dale's colleagues will be able to be on for the rest of our time, but we can talk specifically about the nuts and bolts that Mark shared around planning and financing for capital projects. We could talk a little more broadly about some of the content that Dale and Ron and Nancy talked about, partnering to go into specific types of SDOH-focused initiatives and what the capital needs and implications might be around that. So to start, does anyone have questions for our panelists, or Mark or Dale or Ron or Nancy? Do you have anything that you'd like to expand on a little bit? I'm keeping an eye on the question box, or you can click the hand raise. And remember, we can unmute you. So if you don't feel like typing your whole question or comment out, just raise your hand and we'll try to unmute you. I had a question, and this might get at both Mark and Dale. So Mark, you did talk us through the nuts and bolts of, and thank you for sharing your toolkits and the resources that are on your website. I was curious, when I was listening to Dale and Ron and Nancy talk about these partnership activities they've been involved in, if health centers are partnering to do something like a housing initiative or a transportation initiative or something like that, typically is it the health center that applies for the loan and arranges all of the capital financing, or does that happen on a partnership basis as well? I'm curious what that might look like when you know you need financing to get it done.
That's a good question. This is Mark. We are actually in a learning collaborative with CSH Corporation for Supportive Housing, and really comes down to the idea of how you're planning to position your housing. So, you know, if the health center is part of the housing development, I guess there are times where the health center takes on all the debt and then does a, for lack of a better term, they may have like an apartment or a condo situation within that overarching building. I have seen that happen, but for the most part, the health center typically does their own financing. The housing side does its own financing. And again, it is like a condo situation unless the health center is just going to be located nearby to the housing for easy access. So it really, again, comes back to how they are planning to set up the housing in the health center, whether they're co-located or totally integrated, or if they're in separate buildings altogether. But I think 98% of the time the health center does its own financing and the housing does it, because as Dale mentioned, there's the low-income housing tax credit program. There's new markets, which both can utilize, but the health centers typically utilize that. And you know, there's a variety of different financing sources that may pertain to one or the other. Dale, I'll let you jump in on that too.
Sure, thank you, Mark. While the kind of locating a health center in a housing development certainly has appeal on the surface, if it's, you have to have a bigger patient base than, even if you have a housing, some sort of a housing project with 500 residents. I mean, you know, that's really, you know, kind of small to really make a health center operation very feasible. So we have the first housing unit that we put up is about I don't know, 500 or 1,000 feet maybe away from where our health center is. The health center has its own visibility there. If the purpose of that housing is more therapeutic and to be a step-down unit from an inpatient setting, whether that would be behavior or whether it be mental health or substance abuse, there I think that would make a little more sense to have a primary care provider kind of come through once in a while. It could be in your scope. You may, you know, have a therapist or two or other appropriate individuals where you could bill for the services that would be provided in a setting like that. But if you're just kind of a general housing, you know, that population is generally fairly healthy and doesn't need to see a doctor every day.
Mm-hmm. Got it. And as far as financing for any of these SDOH-related programs that you've talked about, whether it's the medical assistant partnerships that you've done with local colleges and universities, or the transportation initiative that you worked on your own, or this housing stuff, what kind of, can you speak a little bit to the capital needs of some of these projects and the financing needs? And you spoke to that a little bit, and I appreciate it. I wonder if there's anything additional you'd like to tell us, or any specific questions that our participants might have about how to finance their own projects that get at social determinants of health.
Sure. Let me kind of take a quick kind of stab at that one. In regards to transportation, I don't have a good solid figure on the operational costs. The figure that we use on miles to have transport going is around $1.50 a mile. We use that for grant purposes.
Oh, that's an interesting metric.
And then but that cost is really borne by our partner, the hospital, who does the Medicaid billing, and who we, as the health center, we pay the hospital through our Healthy Start grant to provide the additional transportation associated with our Healthy Start patients, the education sessions, and other kinds of activities like that. And those reimbursements really keep it pretty well afloat because because the vans themselves are free.
Got it.
And when the health center doesn't put up any money in that process. In regards to the educational programs, really that relation with that local WorkNet or the old days, the unemployment office, really by working very closely with them, they can put up the funding for that. And so there would be more just what we absorb, and Nancy maybe correct me, but what we absorb is really our staff's time, one like Nancy's time on it, as well as our health center staff, their direct time.
Yes, and I would agree with that. In terms of the mock interviews, it's your health center manager or your HR staff time going to the location to do the mock interview or the job fair. In terms of the externships, those are in-house at the health centers, and that's just a matter of having some senior medical assistants who are patient and have the experience and enjoy educating new MAs on the job.
Have you needed additional space to accommodate those folks, or not necessarily?
Not really, because mainly they are, they might need a locker for their purse and coat, or or jackets, or whatever the case may be. But there is some cost associated with putting them on our EHR system, but that's pretty minimal. And as I said, we have a pretty good track record of hiring the externs who are successful. So they already have a head start on that front, in that they know EHR when they officially become an employee.
That was impressive. I remember hearing you say, I think you said about 90% of people who go through your externships then become an employee of your organization. Did I remember that right?
That's correct, and that's with our Lewis and Clark Junior College. They're the first ones that we've been partnering with for 3 years, and they have an excellent program. So one of the things that's required for the medical assistants to graduate is that they actually pass the registered medical assistant test to receive their certificate from the university. So they come out, they may have an associate's, they may have a certificate, but they all are certified registered medical assistants when they come out, which adds a great deal of value, especially from their technical knowledge.
That's fantastic. And Dale, I'm sorry I interrupted you. Did you have something that you wanted to add to that?
Sure. The only other kind of cost, I think, that Nancy kind of said in general there was that to come into our organization, and probably every other person on the call, but we do like a background check, and Nancy, help me out, but there's a number of things that we do, and those all do take
the university pays for that.
Oh, okay.
Yes, there's no cost for us to bring the externs in.
Thank you. I learned something new.
Yeah,
of course, when we bring them on, then we'll do a full background check. But in advance of that, the drug screen, the educational history, the criminal history, that's all taken care of by the university.
That's fantastic. So that's a really nice way that that partnership is helping this be sort of low resource for you other than staff time, which is not insignificant, I'm sure.
Right.
A question for participants. So participants, listen up, and you can start by using the hand raise feature, or you can type comments right into your question box. But, you know, a huge part of the value of these learning collaborative sessions has been hearing about the experiences of all of you and sharing those experiences with one another. So I'm curious, first, how many of you who have stuck with us to this point in the call are thinking about some sort of expansion? And again, you can just click on that little hand if you want to raise your hand. How many of you are thinking about adding a new program that addresses some social determinants of health? How many are thinking about expanding an existing program? I'd like to get a sense of that. Okay, I see one hand. Great. Ashley, I'm going to unmute you. If you're not comfortable talking or not in a good spot to talk, that's fine. Maybe you can just chat me somehow and let me know. But would you be willing to share with the group, Ashley? I've got you unmuted. Would you be willing to share with the group what you're considering or working on?
Yeah, we're technically, you know, we're just getting started with our telehealth program, but we just hired another case manager that's going to take care of that portion of things. We recently just got a van, and we're going to be doing a little bit with that. We're not, you know, getting the whole insurance thing taken care of and getting all that up and running. But those are our two big additions. One's going to hopefully help with our transportation issue. Actually, both will help with our transportation issues.
Sure.
And just bring a little bit more. We're a very small mountain community, and town is 40 minutes away. So, you know, we have to kind of work with what we got.
That's great. How did you get the van? Did you by chance go through that 5310 program that Dale was talking about?
They have been working towards raising funding and doing a lot for many, many years, long before I came here. And then this year, actually, a local resident donated a handicap van that they were no longer needing. So then it just was a matter of getting it up to, you know, make sure it was in good working condition. And now we're just working on the last little touches of, it was donated to us.
Great. Okay. That's wonderful. It reminds me of those announcements on NPR about donating your old cars. You can donate them to a health center.
Yeah. I wouldn't advertise that too much, though. You might not be good.
Well, that's excellent. Thank you for sharing that, both about your telehealth and the van. And you're right, both of those significantly help to address transportation barriers.
Yeah.
I have a question. Shelby Schofield says that she can't speak because she's in a public area, but wonders about paying for staff time for training externs. And I'm trying to figure out sort of exactly what you're getting at with that question, Shelby. Is the question whether it's okay to pay for staff time? You know, maybe
it might
you have a, yeah.
Kristen, the question may be, do you provide additional pay for the MAs who are training the externs?
Oh, okay. And do you have anything, if that is the question, and Shelby may be able to type in more, but what would you say about that?
We do not pay additional pay to our medical assistants for doing externship training. However, we do have a position called a medical assistant coordinator, which is a promoted position that probably does most of the education and training and provides a little bit of oversight, or provides a lot of oversight on the externs that come in.
Got it. That's great additional context. And I did get some additional information from Shelby about her question. She says that on Molokai, I'm very interested in growing our own, which you're definitely doing there, to become licensed and or certified practitioners, payment that doesn't come under the agency funds, but is there some program that offers other options? So with growing your own, I assume maybe she's talking about, we have existing folks who we would like to take to the next level, and we don't have the funds within our organization to pay for that. Is there a program that can help offer options like that? And she says, I'm getting it right, so that's good. Does anybody know of anything?
Just for clarity, is that nurse practitioners or medical assistant? Kind of which is the question on?
To become she says all. So to become licensed and or certified practitioners, but nurse practitioners, sort of any type of clinical, the growing your own pipeline. How can we take people at one level and help train them to get up to next levels?
On that lower, on the lower level, like medical assistants, if and being on one of the islands there, it might be that's where the community health center, national. Gosh, what is the group here? I got to go back to my notes there. But it's the community health center sponsored medical assistant training program, National Institute for Advancement of Medical Assistants.
Oh, sure.
National Medical Assistant Advancement Group. That because it is all telehealth or teleremote, that might be something that would work well on that lower rung of personnel, and it might be able to you might work with your local WorkNet office to have them pay for that program for the training there. On the nurse practitioner, or on the higher levels, I would say to partner with your community if there's a community college. And my geography is not real good. I'm not sure if there would be any, college or other university within access there, and kind of exploring with them on training, say, LPNs to become RNs or RNs to become nurse practitioners.
Okay.
One thing I would caution on online programs that we have experienced is the MA or RN or LPN, take your pick, may have book smarts, but the hands-on is always missing, because you can't really administer a vaccine to yourself. The whole blood pressure, the hands-on portion of being a clinical person, at some point, I think obviously you can get the basics through online classes, but there needs to be some hands-on education so that the person can take a manual blood pressure, so the person knows what they're doing when they're giving a vaccination, whether it's a subcutaneous or intermodal or intradermal, so that they have the actual hands-on skill sets to do the job.
Yeah, and I think, Nancy, that's where that program, the National Medical Assistant one, you are required to have one of our staff, there to really do skill development a certain number of hours a week, and so they do address that part in that particular program.
Great. So that's a kind of hybrid approach where you can seek the online training from them, which is presumably more cost effective, and then have that on time happen with your existing staff, and then hopefully you'll be able to expand your your capacity and your provider base so much that you'll have to go into the capital expansion resources that Mark shared at the beginning.
Yeah, that's right.
We are at 90 minutes, and I so appreciate the time that we have had with all of you over the last 4 weeks. Please don't forget, we are here to help you. You can call any one of us from the National Cooperative Agreements, and we're happy to have one-on-one conversations and point you toward resources that might fit your specific needs a little bit better. We'd love to stay in touch if you're interested in doing something like this again together and maybe expanding on what we've worked on over the last several weeks. We'd like to hear about that because there will be opportunities to do additional learning collaboratives in the next fiscal year, which for us starts in July. And so if there's a lot of interest in this group and sticking together and going further, we may be able to work that out. So keep that in mind. But again, thank you so much for your participation. It's truly been a pleasure. And thanks a bunch, Mark and Dale and Nancy and Ron, if he's still on.
Just wanted to maybe just real quickly add, if anyone, you can share my email address, phone, whatever, if anyone wants any particular information about the development firm or whoever that we're using, our partners on the housing projects, can maybe steer them to local partners in their areas too, perhaps, you know.
That's wonderful. Thank you for offering that, Dale.
Sure. Thank you.
Mark, do you have any parting comments? I want you to be able to say the last word on this session of yours.
Well, mine is thank you to everybody for participating. And I know some of the numbers I shared were big, but it doesn't mean the smaller projects aren't important. So just keep that in mind, that those resources are good for really any size project. It just, it may not be as in-depth that you have to go into, which is great. But again, I'm available for any questions, and if I don't know the answer, there are a lot of smart folks around here I can forward the question on to. So thanks again, everybody.
Great. Thank you, everyone, and this will conclude our session.